to thank everybody for joining us for our AO Spine North America webinar. And this topic is going to be on clinical biomechanics and spine surgery. We have an excellent panel of speakers that I'll kind of go ahead and introduce. So just to start off with, I am Joe Chang. I am the professor and chair of neurosurgery here at the University of Cincinnati, and it's my pleasure to moderate this session. And then we have two outstanding faculty presenters, experts and really rising stars in our spine field, Dr. Nitin Agrawal, who's an associate professor of neurosurgery and biomedical engineering at the University of Pittsburgh Medical Center, along with Dr. Rania Nasser, associate professor of neurosurgery and director of our spine program for the hospital system here at the University of Cincinnati in Ohio. We're going to have a really packed agenda, but just to kind of go over that, we have nothing really to disclose except for that is listed. Dr. Devine is our educational advisor and evaluator, and his commercial interests are listed there, along with mine, Dr. Agarwal's, and Dr. Nasser's. So, and just to remember that the AO staff in North America have involved in this webinar have no financial disclosures to really, report here. As far as content validation statement, just to let everybody know that AO North America, that we are an independent nonprofit surgical subspecialty society dedicated to the improving care of patients with musculoskeletal injuries. We do not endorse nor promote the use of any specific product or services of commercial entities, even though we may get funding and like support from commercial entities for our educational programs. And that this isn't a course, but if we had equipment, that it is for demonstration and teaching purposes, and we are not out to sell it or promote the sale of that. So in general, why are we having this webinar? And it's really important to understand that, that spinal mechanical or spinal biomechanics, even though it's considered a residency milestone, there is a paucity of formal resident fellow education. And I don't know about everybody else, but anybody that does revisions, you start realizing that the two most common reasons for revision surgeries are complications related to inadequate biomechanics or inadequate diagnosis. And really the goal of this webinar is to help us discuss how we can improve our surgical outcomes in spine surgery. So the learning objectives are, as noted, that we're going to go over some basic principles of spinal mechanics. We're going to talk about the surgical indications for spine stabilization and really instrumentation use. We're going to describe the role of instrumentation in bony fusion. And then hopefully, like I said, you'll get a lot out of this. So just want to go ahead and say welcome, and this is our case agenda. Ronnie, and then I don't know if you want to just say hi to the group.
Hey everybody, thank you for joining us for this educational session. We hope we're able to provide some good educational content tonight, and looking forward to future events.
Good evening, Nitin Agrawal from Pittsburgh. Honored to be with you all, and looking forward to the discussion at the end.
Great. I'm gonna, we're gonna have some cases in the presentations, but I want to just kind of go over an example case and just talk about some of the biomechanical errors or discussions about in pre-surgical planning. So for example, you have this patient come in with an obvious spinal deformity with both coronal and sagittal imbalance. And really some of the questions that you start asking even before you take the patient to surgery are things like, what kind of biomechanical stabilization is needed? And so some of the questions you may ask are things that you would ask anybody. For example, we use the word good carpentry. So if you had a carpenter about to build a deck for you, and they don't really ask you how many people are going to be on it, what's the expected weight load on it, you're going to put an aquarium on there, or is it just going to be, for recreational use, you're going to have big parties. You start really thinking about what kind of load bearing do you need to get for your patients, and then really how do you measure that, and then how does that impact what do you think you need to plan, everything from interbody cages to different material properties. When you decide to use cobalt chrome rod versus commercially pure titanium versus Ti-alloy, or even 316L stainless steel, is it dealer's choice where it's all the same, or the yield strength and material properties of the system important for you to figure out how best to stabilize the forces that you're trying to mitigate? And then same thing with forces is what's an adequate release. People talk about osteotomies all the time, everything from posterior column or Ponti osteotomies to Thomason or pedicle subtraction osteotomies and modified. Some of the questions you have to ask is, what is an adequate osteotomy? How loose should the spine be? Or do you need your instrumentation to apply a load in order to reduce it fully and pre-stress everything overall? I already mentioned about the material properties. How do you choose what kind of hardware? How many levels do you do? What's the thickness of the rod? When do you decide to use a 5.5 rod versus a 6.0 rod versus 1/4 inch or 6.35? Or when can you really get away with a 4.35? And how about the profile on a patient? If the larger the diameter of the rod, the higher the profile, the potential complications. So these are all important things to think about. And then one of the things we'll also go over in some of the talks are things like what is the bone strength after fusion needed to support? Is it good enough just to have a bridging osteophyte across the fusion site? Or how much bone mass do you expect to be there to support the biomechanical loading of the patient's body weight above it? Then we also think about biomechanical errors in post-surgical management. So this is the same patient that then had surgery. Is this appropriate? Is this a good correction? That is there residual biomechanical stress and instability, both in the coronal and sagittal plane? Would this be considered an appropriate surgery or should it have been done differently? So some of the things we'll talk about at the end of the presentations is whether or not we could have done things differently to avoid this type of complication. And then really discuss what are the expected biomechanical failure points. Are the screws going to loosen up from the bone or are the rods going to break? These are things that we'll have to look at and say, can we figure these things out ahead of time versus waiting for it to happen and then say, yeah, what are you going to do? These things happen and we'll just take the patient back to surgery. And then how about the bone quality? What kind of orthoses or adjuncts are needed? How much bone graft do you put in? What's the type of material? How robust of a bone do you need to grow in that area? And these are things that you really need to kind of start thinking about. And then also to follow up in timing. After surgery, is this a patient that you're not going to worry about and see them on a regular interval, 6 weeks, 3 months, a year? Or is it somebody that you want to keep checking on a regular basis, like every few weeks, with x-rays or other tests to kind of assess whether or not they have a good chance of healing or are they going to continue to progress to failure. And then for the same patient, what happens when they fail? So there's a patient that then subsequently presented now with broken hardware and a worsening deformity. What was the mechanical failure mode? Can we really understand what we're trying to fix? Or are we just going to do more of the same and take them back and do the exact same surgery again, hoping for a different result? Did we misunderstand the stresses across the patient's spine, or do we not adequately release? Or did we destabilize things that we didn't realize that create a lot of stability? Or did we choose the wrong biomechanical properties of the hardware that we had brought in or the bone strength? And then when we do revision surgeries, is this more of the same or did we do anything improved or better? Is there residual biomechanical stresses? Where are the failure areas? And the same questions are asked again. How do we follow this patient? Is this good enough or are we going to be worried about something else failing and having to revise this patient yet again? So with that, I am going to kind of turn this over. And like I said, we're going to start off with our first speaker with Dr. Nasser, giving us an overview of biomechanics overall. So I am going to stop sharing my screen and hand it over to Dr. Nasser.
Thank you, Dr. Chang. Good evening, everyone. So as Dr. Chang said, we're going to go over some general principles that we're going to apply to this very, unfortunately common thing we see in a lot of revision spine practices with adult spine deformity. Again, I have no disclosures. And, as Dr. Chang mentioned, it's very important to understand with regards to surgical planning and complication prevention, why biomechanical principles are so important in designing surgical constructs for longevity and sustainability. To go with some of the basic kind of principles that we're going to use to help describe the forces necessary to create these constructs to have sustainable longevity, we're going to go over some terms such as the different forces with regards to the disc spaces, the facet joints, which resist shear, the paraspinal muscles, which we'll talk about distracting forces in a moment. But going through the axial loading forces or the compressive forces, I want to tie this into very relevant clinical examples that we see in daily practice. For example, when we have a compressive force of the lumbar spine, which essentially can result in um, bearing of the vertebral bodies. And when these happens in excessive loads, we see this manifested sometimes in our elderly as osteoporotic compression fractures, and in other circumstances outside of the lumbar spine. These forces also, as we know later on, I'll show you examples in the thoracolumbar spine, but it's relevant because understanding this force can also help us understand the genesis of a lot of degenerative diseases. For example, progressive degeneration of disc height can result in, as we see radiographically, is modic changes, as well as people with symptomatic degenerative disc disease. Going forward in the thoracolumbar spine, in this situation, this is a patient that had a high energy, essentially axial load, which compromised the middle and the anterior column, which essentially resulted in a burst fracture. And as we know in the cervical spine, an axial load applied to the C1 ring is a very common Jefferson fracture, as you can see here. But axial loads, as we know, are not the only loads that our spines undergo. We know that there are lots of bending moments, and bending moments, as shown in this diagram, can result in, one of the most common things that we treat are disc herniations, particularly at L4, 5, and 5-1, due to the increased posterior and annular fiber stress, as you can see here. The thoracolumbar spine, in a more rigid part of the body, an extreme flexion moment can see a flexion distraction injury, as you can imagine, is what we commonly call a chance fracture. And of course, this also applies to the cervical spine as well. And very commonly in patients that have underlying degenerative diseases, this is seen in patients with central cord syndrome. So bending moments also are applicable in deformity. The mechanism for lateral bending moments can progress, for example, in AIS, as well as degenerative scoliosis, and can be a contributing force with coronal imbalance. Furthermore, these mechanisms can contribute to rod fractures, particularly in kyphoscoliosis, which we'll talk about further, which is the case that Dr. Chang presented. And it's a common failure mode in flat back syndrome. With regards to isthmic spondylolisthesis, L5S1, we often see shear forces. And this is oftentimes mitigated by what's known as a slip angle, or how basically steep the sacrum is. If the sacrum is not steep at all, like a table, and you put your cup on a table, it's not going to move. But if it's very steep, it's going to slip, and that's what the shear forces in this diagram are demonstrating. Not just in isthmic spondylolisthesis as seen, but also at L4-5, our facet joints are prone to shear forces that could result in progression of a degenerative spondylolisthesis. With regards to degeneration, as we know, facet syndrome is a source of chronic low back pain from facet inflammation that is essentially a source of repetitive stress from shear sources. And this can also be manifested in commonly seen facet synovial cysts, resulting in lateral recess stenosis, neurogenic claudication, and other commonly seen manifestations. The cervical spine, shear from whiplash injury, myofascial pain are also things that the mechanism is well described. Shear in the thoracic spine as well can result in canal compromise. And shear within the hardware we place is the genesis of proximal junctional kyphosis, as well as mechanical failure of a lot of our different hardware that will go into different metallurgy in later slides. The spine has an excellent classification for these different forces seen in trauma. Compression forces are seen as type A fractures. Distracting forces are seen as type B. And translational, as we all know, is CNC. Now, Dr. Chang made a mention of when you're building a deck, you have to understand who's going to be on this deck, what's the weather, what is this deck going to be used for. And this is a fundamental in metallurgy, which is the stress strain curve. And a lot of these, every implant that you place, whether it's titanium, commercially pure titanium, cobalt chrome, quarter-inch stainless steel, have different yield strengths, which is the stress level beyond when permanent deformation occurs, and different moduluses seen on this curve right over here. And the Young's modulus essentially is the rise over run of the stress over strain. And with regards to tie alloys, there's good fatigue resistance regarding that, but less than cobalt chrome. However, when you look at cobalt chrome, for example, the fatigue resistance is very high, and ultimately it can stress shield more so and result in bony resorption, less fusion, let's say, than something like tie alloy. So when we think about, for example, what titanium has better bony integration, titanium has a oxidized layer, which is excellent for it's bacteriostatic when we're placing hardware into active infections. And this is a good example, for example, of the different moduluses that we see between different properties of these metals. Now, quarter-inch stainless steel has a lot of value with regards to it's rigid but more ductile than cobalt chrome. However, it can corrode, and you can get a biofilm, as well as can be very problematic with regards to MRI imaging. So practically speaking, it can be something that can be prohibitive with regards to placing implants in a patient that has risk for infection or active discus osteomyelitis, or will require more and more MRI follow-up, such as tumors. And this is a good example of the stress shielding and load sharing properties of stainless steel, tie alloy, and cobalt chrome. Stiff implants like cobalt chrome take on more load, however, can potentially stress shield more and result in more bony resorption and less fusion, more non-union. Flexible implants like tie alloy allowed for better load sharing, but regarding fracturing, even though cobalt chrome is more stiff, like a pencil, it also can be more brittle, making it also prone to rod fractures with stress risers at junctional zones. Titanium is more ductile, but can also lead to fretting failure over time. And with regards to these slides will be shared with you if for reference. However, this is an example of the different load versus total displacement of these metals. In principle, titanium has, again, better osteointegration, but lower stress shielding than cobalt chrome. And we have one goal in mind with all of this, which is fusion. And this is just a primer of fusion considerations during the, as Dr. Chang mentioned, what kind of bone graft do you need? How do we enact Wolff's law to get the bony response to ultimately provide the scaffolding for the inflammatory phase, the reparation phase, and the remodeling phase. And the inflammation phase, as we know, is only hours to days. The repair phase goes days to weeks and can take months to years to remodel between the osteoblasts and osteoclasts. And then in terms of biomechanical grafting choices, we have to think about the types of bone graft: autograft, structural autograft, which provides immediate support, allograft, synthetic grafts with bioactive materials such as ceramics, I'm sorry, demineralized bone matrices. And really the principle is we really want, graft that's osteoinductive, osteoconductive, that provides a scaffolding for bone graft with osteogenesis. If autograft is available, and oftentimes with these revisions, fusions and revision deformities, where all the autograft has been harvested locally, this is a consideration that needs to be taken into place when considering how are we going to get this deformity to actually heal. With regards to considerations with stress distribution, the graft has to support the loads in the axial plane as well as torsionally. When the spine rotates, the graft must resist that. And that's with regards to, for example, if we used tricortical crest or a vascularized graft from elsewhere, these are often used in place of if you're doing a VCR for a 3-column osteotomy to span a large region that requires fusion for sustainability. But what if we use something like PEEK? What is really the point of PEEK? PEEK is polyethylethyl ketone, which is hydrophobic, it's inert, and heals by creep substitution. So the difference between structural, autograft versus PEEK, really, biomechanically, in terms of its ability to integrate into the bone, is very important to understand, because PEEK can result in and will heal through creep deformation. If this happens too soon, you can get loss of graft height, leading to undesired kyphosis, altered biomechanics that can affect, the overall construct. And ultimately, the key thing to keep in mind in all of this regarding the implant choices, our bony grafty choices, and how we're going to get this construct to heal is how are we going to align the spine in the most energy efficient manner to minimize the sagittal forces, to get the gravity line where it should be, to avoid the hardware and the biomechanical failures, and matching the PI-LM mismatch. And there's several different grading systems like the GAP score, which go into that, for example. But in essence, getting proper alignment and achieving our corrective goals to essentially make the spine mobile by way of osteotomy, and Nitin will go into different types of considerations for that in his talk, whether it's a patient that would benefit from posterior column resection to mobilize the spine, or require a 3-column osteotomy for a rigid deformity. And that's a very crucial understanding, in terms of biomechanical planning. How are we going to mobilize the spine so that the spine is not, the bone is not being overpowered by the metal, and that the spine is essentially mobile so that you have sustainability. So rod fracture, again, from a biomechanical failure method seen, could happen from not necessarily creating mobility in the spine. PJK is something that can obviously occur from overcorrection or using something very rigid. For example, using titanium versus cobalt chrome, the mismatch between something rigid to the nascent spine can result in PJK. And we'll go into all these different failures in the case that is presented. Nitin?
Thanks, Ronnie.
That was
Great
phenomenal.
talk. Nitin?
Good evening, everybody. My name is Nitin Agarwal. I'm from Pittsburgh. I will try and follow that amazing talk. Uh, my disclosures aren't relevant to the talk, except for one, I have an affiliation with our lab collaboration startup, Novosis Scientific, where I will show you some of our research and implants to try and address current issues with implant and plate mismatch. None of the products are commercially available. Biomechanics and surgical planning was my task. And why does it matter? Well, as Ronnie had mentioned and alluded to, we need to optimize fusion success in order to achieve functional recovery, prevent mechanical failure, and there are scores, like you mentioned, like the GAP score, to help estimate and prevent mechanical failure. And lastly, and most importantly, we wanted to determine load distribution and post-surgical stability so we can achieve the first two. In other words, fusion and prevent failures. Well, how can we do that? What are the preoperative considerations? Nowadays, almost everybody's looking at spinal alignment and balance, and as well as the patient factors that go into optimizing somebody for the spine. A host of software exists to help with planning, and we are going to continue to see the integration of AI to really optimize this process. But equally important are the patient factors. And I think as part of patient planning in our practice, we have a good collaboration with our endocrinologists to try and optimize bone strength to get a good outcome. Along with those two things, we can modify based on the patient's preoperative factors or surgical planning, our pedicle screws and rod constructs. Do we have a load sharing versus a load bearing construct? What about our rod stiffness? Ronnie alluded to titanium versus cobalt chrome as the two primary rods being used right now, and the pull-out risks associated with that versus rod breakage. Do I use a stronger rod, cobalt chrome rod, maybe 6.0 cobalt chrome versus a titanium 5.0 rod, but risk breakage? Interbody fusion approaches, I think the different types of implants continue to grow, and each implant has its own risk profile, but also its own biomechanical risk profile. When you have a larger graft with more end plate coverage, such as an A-lift, an anterior lumbar interbody fusion, or an L-lift, a lateral lumbar interbody fusion, our ability to bear loads increases as opposed to perhaps a T-lift. And lastly, there are considerations with the smaller surgeries on the use of arthroplasty. I think that the best way to address surgical planning are perhaps my surgical planning mistakes and failures, and how I've changed my practice over time. So this is a case early in practice. I had a 78-year-old male, as most of you all do. This is a big part of our practice. Epidural abscess. The question is how far, how many laminectomies, and what time in the night am I going to go. For us, it's a surgical emergency. Epidural abscess goes right when it comes, especially when there's cord compression. This gentleman had a C3 to 7 epidural abscess with severe cord compression and some weakness. I think the first things to consider here are the normal spine biomechanics, and Ronnie really touched upon this, but for me, a failure to understand the difference between lumbar spine support and cervical spine support was crucial in this case. Most of you already know this, that lumbar spine 80% in the anterior column versus the cervical spine 36 to 40% in the anterior column. The majority of the load is carried by the posterior column and the posterior tension band as we go more rostral, and it becomes very important in the cervical spine. In addition, the pathologies that we deal with can also have biomechanical effects and compromise bone weakening, soft tissue damage, compromised mechanical integrity. The facet joints can be affected as well as the discs. It's probably no surprise what happened in this case. Intra-op, you can already see this patient appears to be kyphotic, and post-op, even more kyphotic. Now, fortunately for me, this patient presented back in clinic not paralyzed, but certainly this is not a fun picture to see when the patient walked in and could not look up and was looking at the floor. Well, why do biomechanics matter? Progressive deformity, an inability to maintain a horizontal gait, obviously mechanical neck pain, but perhaps the most important are the latter two: spinal cord compromise. This ventral compression from buckling of the anterior column and tracts. Really, you see the effects of cervical myelopathy, but even more importantly, spinal cord injury and weakness associated with that. I think not only do biomechanics play a role for decision making, but also when we have to correct these iatrogenic mistakes, how do we do so? The patient had progressive kyphotic deformity, myeloradiculopathy, and severe neck pain. And the biomechanical considerations really here is up front, the patient had an epidural abscess from C3 to 7. Perhaps at that time I could have done something smaller in line with that decompression, a smaller fixation. But now we're really dealing with a high stress zone at C7 T1. And do I perform a hybrid construct anterior posterior or just posterior to really shore this patient up? And as Dr. Nasser alluded to, how much correction is required to get an optimal alignment? Really, the problem here is the posterior tension band is gone, and we need to replace that posterior tension band and perhaps anterior cervical discectomy and fusion to shore up that construct. I think this is learning point 2 for me, is I chose a posterior vector to stabilize and realign the patient with minimal osteotomy. But if I was really hypercritical with this case and I look at this, although the patient has a horizontal gaze, their occiput is still anterior to the thorax here. And quite frankly, I think additional either posterior releases or anterior support could help get this patient in a better alignment. So far, they've not presented again, but it's only a matter of time. Of note, as Dr. Nasser alluded to, I chose titanium rods, given the issues with bone quality as well. The considerations for me at this point in time: problem number 1, loss of posterior tension band, and basically an unrestrained flexion movement, and using posterior instrumentation to really replace that missing tension band. Anterior column overload, without that posterior tension support, increased stress on the vertebral body, and again, posterior stability to augment that and spread the forces along the larger construct, as opposed to a short C3 to 7, really crossing that 7-1 junction. Increased shear forces from, again, due to that loss of tension band. And I think we cannot discount this enough. The fact of abnormal muscular loading, anytime a surgery is performed, those extensor muscles are now dissected away and can lead to a worsening kyphosis, as there's no support there. And what can we do to really minimize the damage to native musculature? I think as advances grow with minimally invasive technology, this should be a boon. After that case, I thought I got a little bit better in time, so I'll share a thoracolumbar case with all of you. This 52-year-old male had numerous different surgeries, and you can see in abnormal alignment when he presented to my clinic, really a jigsaw puzzle of surgeries in the back there with several different constructs, both in his cervical spine and his thoracolumbar spine with intractable back pain. But primarily, he's not aligned. And how do we address something like this? Well, the first thing I did was remove everything in the back to really release the spine, as Dr. Chang had alluded to, in order to allow us to get back into a normal alignment. You can see pre-op to post-op, we were able to improve his alignment, but this was through a series of stages. And in reality here, one approach might be a very large osteotomy, but in order to try and minimize complications, I chose to take advantage of the anterior column in the lumbar spine with large ALIF grafts there, assisted by posterior column osteotomies, to further release the spine and get this person back in normal alignment. The real learning point here for me, though, is 2 rods enough? You can see the cervical spine is assisted with a multi-rod construct there, but in the lower spine, will that hold over time? He's a young male with really strong bone, but I really question whether 2 rods for this cervical, thoracic, lumbar construct will keep this person intact. He's not had rod breakages yet, but it's a important consideration here. the type of osteotomies to achieve our biomechanical goals of optimal sagittal balance, minimize implant fatigue and failure, and reduce reoperation risk must be considered. I think for the thoracolumbar spine, it mimics the cervical spine in terms of our goals. For this case, one additional consideration is the SI joint, the sacroiliac joint, and the considerations with that, with the pain transmitted from the spine down to the pelvis, and as I mentioned, the integrity of the construct with just 2 rods from cervical all the way down to the pelvis. Well, one thing I want to discuss is biomechanical research and why does it matter? Well, part of our planning is to predict mechanical failures before they occur with things like the GAP score, enhancing surgical precision and implant selection, and reducing complications and reoperation rates. And this is a little bit more in the research realm, but I think it's going to play more of an impact as we go with time with surgical planning. One of the things that I'm interested in collaboration with our engineering department, is 3D printable technology to really mimic our implants to the spine. So we have individualized medicine. Early on, I was looking at elastic modulus of different interbody implants, and I think this is the key. Can we match our implants to the spine in order to try and minimize the invasiveness of our surgery and also improve our outcomes? And then can these implants actually monitor what is the strain that the spine is experiencing? I think when we're able to do that and we have live monitoring, we will have a lot more success. And aside from just implants, what about our rods? Can we make rods that are not just one stiffness all throughout, and reduce the incidence of PJK, reduce the incidence of adjacent segment disease, create a soft landing, quote unquote, evenly distribute the load? Our future directions for patient planning: patient-specific surgical plans using AI and machine learning, advances in our biomaterials for spinal implants, and the role of robotics and AI in biomechanical optimization. Thank you to my research lab, especially Aisha, for their assistance.
Great. Thanks, then. We do have a question as I'm go ahead and pull the case back up by Dr. Zaya Ong, asking, is there any role for glucosamine, chondroitin, collagen, hyaluronic acid, oral medication for set joint stress or old age and osteoarthritis? Ronnie, do you want to take that?
Yeah, so I think in terms of overall, like in terms of bone optimization, Z-score 1.5, we want to make sure that the parathyroid and obviously calcium, vitamin D levels are all optimized from that end. But with regards to is it glucosamine and chondroitin? Was that the supplement that was asked in collagen?
Yes.
I'm unaware of any large studies that have given recommendations with regards towards that. And I think there's no evidence-based medicine that would make that a tier 1 recommendation. Do you do that in your practice, Nitin?
I don't. Sorry, I do not. I think the concept of supporting collagen growth and integrity makes sense in practice, but again, I'm not aware of any studies.
Good. All right. I think that was our only kind of question. So I pulled that case back up. And one of the things I want to do for our audience and especially our fellows is to kind of walk through this and just talk about how you make surgical decisions. So for example, this patient with his AP and lateral, one of the things that I think was alluded to by both of you is that we really don't even take into consideration the soft tissue. For example, the muscle changes in the MRI scan to chronic strain, separation of the multifidi from its insertion site on the spinous process. And I guess maybe the question to start off with is, maybe we'll start with you, Nitin, is for a case like this patient shows up to clinic, what kind of testing and evaluation and what are you thinking of as far as things that you would need to help you make a surgical decision, because versus just hey, these are, this is the x-rays and we're just going to fixate based on what the bones look like?
I want to touch base real quickly on your point about the muscle jacket. I think that's probably the most important thing that we are lacking in terms of how to target that for optimization. We target almost everything else except for that. And I think that, as I alluded to, that AI and being able to segment the muscle will really be helpful in the future, especially when we're thinking about things like fatty infiltration and whether this person's going to be able to withstand the forces of a stiff construct next to the native bone. In terms of um, evaluating the patient for pre-surgical planning before considering an operation, I actually think before even the alignment considerations or what screws or hardware we're going to use, the number one factors for me are patient selection and patient factors. What is their bone quality, household units, DEXA scan, what's their nutrition status, their pre-albumin or their albumin level, what's their BMI. I think most of us have a BMI cutoff. Quite frankly, I think it's a little too high still, even for all of us, for these larger constructs. It's hard in the Midwest or East Coast, or when you're in Pittsburgh or Pennsylvania or Ohio, to get a BMI under 35. But now with the new medications, it is actually very possible and very rapidly achievable. So those patient factors for me, I think, are paramount. And each patient goes through a rigid screening for them before we even consider what surgical plan are we going to have, what sound construct are we going to have.
Yeah, Ronnie?
That's a great point. So looking at the cross-sectional area, for example, of the muscle to look for fatty infiltrate versus scar tissue, as Dr. Chang mentioned, these 3-4 time revisions oftentimes have no posterior tension band. There's no multifidi. There's no longismus. Even ilicostalis can be compromised. So from that end, there obviously there are sarcopenic scores to test the muscular envelope, but a very simple thing to do is something that's functional and easy to do in the clinic is a trunk endurance test, which is or known as a Sorensen test, where the patient lies prone face down and see if they're able to maintain that position and for a period of time, and essentially, you have functional extensor muscles. But radiographically, when this is the case, it does change your management with regards to not depending on that muscular envelope for your posterior tension band and potentially having to augment that with hardware.
So just to kind of clarify, during clinic, when you're doing the various testing, what kind of parameters are you looking for to decide, for example, the extent of surgery? Like, obviously, we talked about an MRI scan looking at the soft tissue. But like a case like this, patient has a slight pelvic obliquity, leg length discrepancy overall. How straight do you want to make them? And then, because once you decide how straight you want to make them, then you can talk about like what levels to do, where do you stop? And then where do you start with this? Like with a pelvic obliquity, do you put them in a shoe lift and then look at their parameters? You just go ahead and measure the parameters based on, their leg length. What do you do?
Yeah, I think that's a great point. Each time I see a pelvic obliquity, my knee gut reaction is, where's the EOS scan? Let me measure their leg lengths. Am I looking at the central sacral vertical line, or now do I look at the central sacral pelvic vertical line? So I think number one is getting some more information and more data here. I think getting that full length X-ray plus legs to see what their discrepancy is important. I think that you could obviously just do a measurement, a manual measurement in clinic, but oftentimes what we're finding is each of these patients are now not presenting with just a scoliosis or a deformity. They're presenting after some sort of hip implant, knee implant, some sort of other hardware that's been performed. And getting a full, complete picture of that I think, is important for construct planning, because if we just fixate this spine and leave that obliquity there, we're setting up for more surgery.
Well,
That's
obviously, I'm sorry, go ahead, Ronnie.
that's a great point. And another thing to note, sometimes when people have, for example, you mentioned hip pathology or iatrogenic or otherwise, and they have a pelvic obliquity, checking for a hip flexion contracture can sometimes, if that is an underlying confounder, can really give you an idea of what the patient's actual baseline should be, and getting that kind of evaluated and treated.
Points. So when we're looking at the biomechanics, we talk about just, things like improving balance, is just as you alluded to, Ronnie, lining up load vectors, for that. So this is a patient that had this surgery. Maybe we'll start with you, Ronnie. What's wrong with the surgery? Like on the surface, this looks like it's okay, but obviously it failed. Do you think this is something that you would expect to fail? Should the surgery have been done different or better in a certain way? Or do you think, you know, and if can, what do you think where the mistakes were made? Is it the material choices, under correction? What's your thoughts?
Yeah, so I have a few of them. So, so kyphoscoliosis, this patient, in my opinion, was undercorrected. The gravity line's too forward. Now, you mentioned material choices. If cobalt chrome was used, it might have, been more resistant to fracture due to the higher strength and fatigue resistance. However, it would have failed later because, one of the reasons this failed was the fact that there was pseudoarthrosis as well. No bony, you don't see any bony fusion. You don't see robust bone graft posterolaterally. So basically the genesis of this patient's failure was under correction, by means of not performing enough osteotomies or for performing the right osteotomy, if this is, for example, a fixed deformity that required something more aggressive versus posterior column osteotomy on a small disc space that's not going to really open up for you, as well as a failure with pseudoarthrosis, lack of grafting. And if you go to I guess the last picture, it looks like in the revision, they addressed that by adding more fusion surfaces. And mentioned 80% of the axial loads go through the anterior column. So by adding additional anterior column support, by providing more fusion surface, and then providing an osteotomy that would mobilize the spine, would probably have avoided this failure up front.
Then what would you do? I mean, this is, I'm sure, with all some of these cases, they're a slog, big patients, a lot of blood loss, got to quit eventually. This is a case that you would say, well, post-op x-rays, you know what, I'm going to talk to this patient about taking him back again, or even staging it and saying, you know what, I totally did, I undercorrected your spine. I'm going to go back and revise what I just did. Or would you put him in a brace, bone growth stimulator? How would you handle this situation if the patient presented like this?
Number one, I'm going to say whoever did this is a fabulous surgeon. So I don't see anything wrong. But look, I think when surgery's tough, and when we have a post-op patient, it's easy to critique and say, let me do something better. I think that once the patient's out of the operating room, I think you mentioned a very good point. These surgeries have high blood loss. The patients go through a lot of, and even if the patient's undercorrected, I'm very reticent to take them back right away. I think that I'd rather have the patient declare themselves. And there are a lot of other things I think that can be done in the meantime to try and mitigate an immediate failure. This patient, I'm always leery when I see an X-ray and the patient is off the screen. So, this patient, weight loss management, although it might not prevent a complication, reduce BMI, reduce stress on the construct in the interim, especially with the new medications we have, I think would be a number one. Number two, activities like swimming, once the wound's healed, try and increase their musculature and muscle jacket. I think that Ronnie made very good points about correction and osteotomies to get a better alignment. But the primary question of, would I take this person back because I'm expecting them to fail? I wouldn't. I think that we need to make sure that we treat the patient first, and just taking him back on a radiographic picture, we know that over time, standing films do improve from their immediate standing film picture as these people are able to stand up again and get over the initial postoperative pain.
Point. Can you kind of comment on, you're talking about the soft tissue. So obviously the patient's not fitting within the single cassette that we have here. How do you approach a patient that has a, large pannus, like someone that's overweight? I know we try to have cutoffs, but sometimes even the body the cutoffs, the body morphology is a little different, right? Versus the apple
It
versus the
actually
pear.
makes the posterior column osteotomy easier because the pandas pushes everything forward.
Fair enough. But do you choose a different construct? Like for example, do you switch to cobalt chrome if you're trying to have an increased a little bit more stiffness and you think the bone can handle it? Um, do you ever use like cobalt chrome plus Ti alloy versus commercially pure titanium? What's your thought process when it comes to saying, all right, I'm not going to correct this patient 100%, but boy, do I use a quad rod or versus using a thicker rod or a kickstand? What's your thought process on that?
Well, I mean,
Nitin,
I'll
you
go
want to start?
first. I mean,
Yeah.
if you're forced to operate, which I never think you are, but if you were forced to operate, let's say it's a trauma situation, would be the only one I can think of, that you have a very large patient, three-column injury, and you have to do it. Then I think it is very reasonable. Four-rod construct, cobalt chrome, large pedicle screws. I think often we don't fill up the entire diameter of the pedicle, so get at least 80% of that pedicle or more. Um, those are all things that we could do to mitigate the risk of construct failure and to match the construct to the patient's habitus. I do think that though, in the absence of a trauma setting or surgical emergency such as epidural abscess with vertebral body compromise, the best thing to do is patient health and optimization.
Ronnie?
Yeah, it's a great point. I mean, obviously, it's we don't live in the coasts where people have BMIs that are optimal. So people do their best and they need to return to work and you give them a year, they're still disabled. They and ultimately when it becomes safe to do so, in these situations, if you have essentially the most unstable part of the spine, which is the osteotomy. So you want to give that the most stability by way of either quad rod and I've used accessory rods. I use that over any three-column osteotomy. I'll certainly do that over a posterior column osteotomy that's going to essentially have less fusion surface, because what is your fusion surface? There's no facets because you've removed them.
Mhm.
You don't have unless you're doing a Suk osteotomy with an inner body, essentially, and compressing. There's no actual fusion surface. You're depending on bone essentially growing around your graft placement. So you do need to stress shield that area. And that's the highest likely area to fail. So I would use accessory rods.
Yeah, I would agree with you. I think, for example, if you look at this lateral x-ray, it looks like a schlag when you're trying to bend rods to kind of fit like that. And so I suspect multiple bends were made. Then we talked about like titanium having, notch sensitivity. And when you bend it more than once, you severely weaken it pretty quickly. The whole idea of multiple small bends versus, big bends. The other thing is, as you guys alluded to, is just really, the lever arm. So for example, with a larger anterior, I guess if you look at where the gravity line is, say, the proxy of the C7 plumb line, you can see that you're probably going to have a bending moment exactly probably where this thing would fracture, at the transition point. So one of the things is, this thing fractured now. So obviously not 100% unexpected, given that this rod system may have been undersized, with more of a 5.5 or 6.0 rod. And if you can't increase the material properties of it, I agree with you. You just have to increase the relative diameter, so that if you can't increase the relative diameter, they call it a bundle of sticks where you just add more rods in it just to now the only problem with adding more rods is that you do create areas of pseudo where kind of like I guess it's not a pseudomeningocele, but like a seroma pocket because you prevent the soft tissues from laying down. You tent it up over the dura. But now the thing's failed. How would you fix it? Do you think, how would you approach it? I mean, this is obviously what was done, but do you think you would have done the same thing with just fixing that one broken area to support it? Or would you revise this, corrected it differently, extended it up? Then what would you do with this?
I think that as time has gone on, surgery has become easier for us in the sense that emerging technology allows us many options to correct. Gone are the days where it's, well, here's just your Harrington rod or stainless steel rod, and good luck. So one thing is to take advantage of the disc space. I think the more we take advantage of the disc space, the less complications, the less morbidity. Things like lateral inner bodies here at the point of breakage are options, especially higher up, where you may be worried about spinal cord, maybe L1, 2. You rather come in from a lateral approach. So I think taking advantage of the disc space, no matter how you want to do it, can help shore up the construct and potentially minimize the number of rods you need to add on to this. Secondly, I do think that clearly there's a rod breakage here, so this requires support. One interesting concept that I have been playing with is the concept of having primary rods as titanium rods and then strong accessory rods that are cobalt chrome rods. I don't think there's a clear definition right now on what is the best combination of rods in terms of materials that will minimize a mismatch between patient native bone and implant versus rod integrity. But I think once that's really understood with the use of AI, that will be very helpful.
Ronnie, any last suggestions for this case?
Yeah, so this isn't a screw pull-out case, this is a rod fracture case. So that being said, I agree with a stronger implant. I would explant the metal. I wouldn't try to Fisher Price things together. I would take it out. I would mobilize the spine by way of osteotomy. I would provide fusion surface by way of interbody. Since you have a clean shot of the disc space because you're doing a posterior column osteotomy, presumably, I would do it all through one stage in the back. And I would do a bundle of sticks, as you alluded to, with quad rods over the failure point, as well as harvest something osteogenic, conductive, and inductive from the crest to provide scaffolding for sustainability and bone growth.
Great. All right. I want to thank you both for really some great talks and some good insights into how we approach some of these challenges in biomechanics, just because, especially deformities and some of the things, we didn't get into a lot of the meat of it. For example, Nin alluded to trauma, which is a different type of biomechanical injury, and that's one of the reasons I think people are okay doing, unilateral or bilateral fixation and argue about facet fixation and such higher up. But when you have an L5 burst fracture, that needs a lumbopelvic stabilization, all of a sudden it's like, wow, that's a whole different biomechanics. With that, I want to thank you both. I just want to kind of talk about that. We have the AO Spine webinar series. We have some upcoming webinars, as you see there, for the audience, along with our online case consult series, which will go over some really interesting cases, for the sessions. We have our one AO meeting coming up in Henderson, Nevada, which is really just adjacent to Las Vegas. So overall, that's April 24th to 25th, and we will have the 1AO principles courses for our residents. That is April 22nd and 28th. For both trauma and spine. So please, if you get a chance, that's the QR code for the link to go to the 1AO meeting. With that, I want to thank Dr. Nasser, Dr. Agarwal, Mackenzie, Abby for helping host a great biomechanics webinar. And with that, I want to say good night to everybody.